At age 71, he finally reached his doctor's ideal weight. His BMI was perfect. His blood pressure had improved. His blood tests looked better than they had in years. By every standard clinical measure, this man had done it. He had followed every instruction, hit every target, crossed every finish line medicine had drawn for him. 14 months later, he was dead. And what researchers discovered afterward sent a quiet shockwave through the medical community, because his story was not an isolated case. It was a pattern, a disturbing, well-documented, deeply inconvenient pattern that is forcing scientists to reconsider one of the most fundamental assumptions in elderly healthcare. The assumption that after 65, losing weight is always the right call. If someone you love is over 65, or if you are, what you are about to hear could genuinely change how you think about their body, their health, and the number on their scale. And if you haven't subscribed to this channel yet, this is a good moment. We cover the medical stories that don't fit neatly into the headlines. To understand what is happening, we need to go back to 2005. A researcher named Catherine Flegel was working at the Centers for Disease Control and Prevention in Atlanta. She was running what should have been a routine analysis, compiling mortality data across tens of thousands of Americans, tracking the relationship between body weight and death rates over years. When the results came in, she ran them again, then a third time, because what the data said made no sense. People classified as overweight, not obese, just overweight, sitting in the BMI zone between 25 and 30, were dying at lower rates than people classified as normal weight, not slightly lower, meaningfully, consistently, reproducibly lower. She brought in colleagues. They checked the data set from every angle. There were no errors. The pattern was real. The paper was published in the Journal of the American Medical Association, and the scientific community's response was not curiosity, it was fury. Prominent researchers wrote letters demanding retraction. One Harvard epidemiologist publicly dismissed the findings as rubbish. The criticism was not just scientific, it was personal. Flegel was accused of being irresponsible, of undermining decades of public health messaging, of giving people permission to be unhealthy. But here's what none of her critics could do: disprove the data. Because the data kept replicating. Researchers in Europe ran similar analyses. Japan ran similar analyses. Canada, Australia, multiple independent teams using entirely different data sets. They kept finding the same signal. The pattern was real. And the more carefully scientists examined it, the more specific it became. Because it was not universal. The effect was strongest in one particular group. One age range where carrying a little extra weight seemed to matter most. People over 65. Now, before we go further, there is something important to be precise about. The research does not say that extreme obesity is protective. It does not say that gaining as much weight as possible is a health strategy. What the data points to is a specific zone, a BMI between 25 and 30, what medicine officially classifies as overweight. That moderate, relatively small degree of extra weight. In older adults, staying in that zone is associated with longer survival compared to being in the so-called normal range. And the biology behind why is where this story becomes genuinely fascinating. The human body at 65 is not the same biological machine it was at 40. It looks similar on the outside, but the internal rules have shifted. The survival priorities have changed. What protects you at 35 can become a liability at 70. And what the medical world has been telling older adults to lose may be, in some critical physiological ways, exactly what their bodies need to keep. Here's where things start getting disturbing. Imagine two men, both 72, both physically active, both sharp mentally, both with broadly similar health histories. One weighs 160 pounds at 5'9", a textbook normal BMI. The other weighs 185 pounds at the same height, technically overweight by every clinical guideline. Then one of them gets pneumonia. Pneumonia in an elderly person is not just a chest infection. It is a full-body metabolic emergency. The immune system floods the body with inflammatory signals. Fever burns through calories at a dramatically accelerated rate. Appetite disappears. And for days, sometimes 2 weeks, the patient is barely eating while their body wages an internal war that demands enormous quantities of fuel. The lighter man's body has limited reserves to draw from. His fat stores are minimal. His muscle mass, already under attack from an age-related process called sarcopenia, cannot be easily sacrificed without serious functional consequences. His body begins, almost immediately, breaking down whatever it can access to fuel the immune response. Muscle tissue, bone proteins, the structural materials that keep him upright, balanced, and mobile. The heavier man draws from fat. Fat that his doctor had spent years encouraging him to lose. Fat that clinical guidelines classified as a health risk. That fat becomes a metabolic bank account, a reserve he withdraws from across 2 weeks of illness. When he recovers, he is thinner and weaker, but his structural tissues are relatively intact. He goes home. He rebuilds. This is not a metaphor. This is documented biochemistry, and it plays out not just in pneumonia, but in every major illness, every surgery, every hospitalization that an aging body has to endure. Researchers at the University of California studied hospitalized patients over 70 and found that those who were mildly overweight at the time of admission had significantly better survival rates during acute illness than patients who were at normal weight or underweight. The overweight patients often stayed in the hospital longer, but they came home more frequently. But that is only the beginning of this story, because there is something else happening in elderly bodies that researchers did not fully understand until they started studying what happens when older people intentionally lose weight. When a younger adult loses weight, the body responds in a fairly predictable way. Fat decreases, blood pressure typically improves, insulin sensitivity rises, the system runs more efficiently. When a person over 65 loses weight, something very different happens. They don't just lose fat, they lose muscle. In the hormonal environment of aging, with lower testosterone, lower estrogen, altered growth hormone signaling, the body finds it extraordinarily difficult to shed fat without simultaneously losing lean muscle mass. Research has found that in elderly adults undergoing intentional caloric restriction, somewhere between 30 and 50% of total weight lost is not fat, it is muscle. And muscle loss in an older person is not a cosmetic concern. It is one of the most dangerous biological changes that can happen to an aging body. Muscle loss in the elderly dramatically accelerates fall risk. Falls are the leading cause of injury-related death in Americans over 65. More than 36 million falls occur in the United States each year among older adults. Over 32,000 of them are fatal. And for every pound of lean muscle an elderly person loses, the probability of a catastrophic fall increases. A fall leads to a fracture. A fracture, particularly a hip fracture, triggers a cascade of complications that research has traced with devastating clarity. The Journal of Bone and Mineral Research found that hip fracture patients over 75 carry a 1-year mortality rate approaching 30%. Not from the fracture itself, from what follows. Pneumonia from weeks of immobility, blood clots, prolonged hospitalization, secondary infections. Now, connect those threads. An older adult loses weight. Along with the fat, they lose muscle. Their balance deteriorates. Their fall risk climbs. They fall. They fracture a hip. Nearly 1 in 3 of them does not survive the following year. And the chain began with a recommendation that seemed, by every standard guideline, completely appropriate. This is not a fringe concern. It is a replicated, published finding that researchers in geriatric medicine have been trying to bring into mainstream clinical conversation for over a decade. The question worth sitting with is, why has that conversation been so slow to change? There is a concept in medicine called clinical inertia. It describes the tendency of well-trained, well-intentioned clinicians to continue doing what the guidelines say, even when emerging evidence suggests the guidelines may not apply equally to every patient population. It is not negligence. It is not bad faith. It is something more understandable and more human than either. For decades, the message around weight and health has been remarkably consistent. BMI above 25 increases risk. Reaching a healthy weight protects the heart, reduces diabetes risk, eases joint pressure. This message was reinforced in medical school curricula, embedded in clinical guidelines, amplified in public health campaigns. It became professional consensus. And consensus, once established, has enormous inertia. What the obesity paradox research reveals is something that medicine is gradually and somewhat uncomfortably beginning to absorb. Guidelines developed primarily in studies of middle-aged adults may not translate directly to adults over 65. The biology is different. The risks are weighted differently. The interventions that make sense at 50 require reconsideration at 75. This is not a failure of medicine. It is medicine doing what medicine eventually does, updating, refining, becoming more specific. But the pace of that update matters when real people are receiving real recommendations in real examination rooms every day. And what happens in those examination rooms is where this becomes personal. Think about what happens when a 70-year-old woman goes to her annual checkup. She feels reasonably well. Her energy is adequate. She moves around with minor difficulty. By her own assessment, she is doing okay for her age. The nurse takes her weight. The BMI calculator runs. It says 27, overweight. Her physician, following established guidelines, raises the subject. A gentle suggestion that losing some weight would benefit her heart, ease her joints, reduce her long-term risk. The conversation is well-meaning. The physician is following the best available standard of care as they were trained to understand it. She goes home. She reduces her calories. Over the following year, she loses 15 pounds. At her next checkup, her BMI is 24, normal. Her physician is pleased. But what the scale does not show, what no routine measurement captures, is what else changed during that year of caloric restriction. Her muscle mass declined. Her bone density, already under pressure from age-related hormonal changes, decreased further. Her grip strength, a measure researchers have now identified as one of the most powerful predictors of elderly survival, weakened. Her balance subtly deteriorated. The number improved, but the body became more fragile. This is the paradox at its most human and most consequential. A clinically meaningful metric is being optimized, and in older adults, that optimization may sometimes be working against the very survival it is meant to protect. Now let's talk about bone, because this story goes deeper than muscle alone. Osteoporosis affects an estimated 54 million Americans. It is predominantly a disease of older adults, particularly women, and it is silent until a bone breaks. By the time a fracture reveals it, the damage is often severe and long-standing. What rarely surfaces in mainstream health conversations is that body weight is one of the most consistent natural stimuli for bone density maintenance. The mechanical load of carrying extra body mass forces the skeletal system to continuously reinforce itself. Bone responds to physical stress by building. A body carrying a BMI of 27 is applying more sustained mechanical stimulus to its skeleton than a body carrying a BMI of 22. Over years, this sustained loading can meaningfully preserve bone density in ways that supplementation alone cannot replicate. When an older person loses significant weight, that mechanical stimulus is reduced. The bones, receiving less load, begin to lose density at an accelerated rate. Studies have repeatedly documented that intentional weight loss in postmenopausal women accelerates bone density decline, even when calcium and vitamin D supplementation is part of the program. The mechanical stimulus of body weight cannot be replaced by pills, and yet the prescription continues. Lose weight. Reach a healthy BMI. For a population whose bones are already in a daily battle against the forces of aging. There is one final dimension to this that science is only beginning to map, and it may be the most surprising. Fat tissue in the body is not inert storage. It is metabolically active. It produces hormones. It secretes signaling molecules that communicate with the immune system, the cardiovascular system, the brain. And in older adults, some of what fat produces appears to be performing protective functions that researchers did not fully anticipate. One of those molecules is leptin. Most people know leptin as a fullness signal, the hormone that tells the brain the body has enough fuel. But leptin's role extends far beyond appetite regulation. It is involved in immune system function, bone metabolism, cardiovascular regulation, and emerging research suggests it plays a role in neurological protection. Here is something that does not get much attention. Leptin levels decline with age, and lower leptin levels in elderly adults have been linked to increased susceptibility to infection, accelerated cognitive decline, and higher rates of cardiovascular events. Older adults carrying a slightly higher body weight in that moderate overweight zone have higher circulating leptin levels than their leaner counterparts. And that leptin may be doing biological work that thinner elderly bodies simply cannot access. This research is still developing. The mechanisms are complex, but the picture being assembled points towards something that would have seemed counterintuitive a generation ago. In older bodies, a moderate degree of extra fat tissue may be actively participating in survival biology, not just sitting there passively, actually working. So what does all of this mean in practical terms? What should you actually do with this information? First, and this is the most important shift, stop treating the number on the scale as the primary indicator of health after 65. It was never designed to be. BMI was developed in the 1800s by a Belgian mathematician for the purpose of studying population statistics. He explicitly stated it was not meant to measure individual health. It is a population tool being used as a personal health verdict, and in older adults especially, it misses what matters most. What matters is what you are made of. Not just how much you weigh, but what kind of mass you are carrying. The research on this is consistent and increasingly urgent. After 65, the goals that actually predict survival and quality of life are not found on a scale. They are found in the following measures. Grip strength. The ability to squeeze something firmly with your hands is a remarkably powerful proxy for total body muscle mass and overall biological vitality. Studies in Japan, tracking elderly adults over multiple years, found grip strength to be among the strongest predictors of who survived with good functional health, outperforming BMI, outperforming cholesterol, outperforming many of the standard clinical markers that routine checkups focus on. Walking speed. How quickly and steadily you can walk across a room tells researchers something important about your neurological integrity, your cardiovascular health, your muscle function, and your fall risk all at once. Maintaining or improving walking speed is a meaningful health target, the ability to rise from a chair without using your arms. This single movement, sit to stand without pushing off, is a direct test of leg strength and core stability. It is one of the most predictive functional tests in geriatric medicine and one of the easiest to practice at home. Protein intake. The average older American is not eating enough protein. After 65, the body's ability to build and maintain muscle from dietary protein becomes less efficient, meaning older adults actually need more protein per pound of body weight than younger adults, not less. Most are getting significantly less than they need. The result is accelerated muscle loss that no amount of caloric restriction is going to reverse. Resistance training. This is the single most evidence-supported intervention available for healthy aging. Lifting weights, working against resistance, training the muscles to push and pull. It preserves muscle mass, stimulates bone remodeling, improves balance, reduces fall risk, and extends functional independence. A 75-year-old who does resistance training 3 times a week and carries a BMI of 27 is, by most meaningful biological measures, in better shape than a 75-year-old who is sedentary with a BMI of 22. The scale says one is healthier. The biology disagrees. Balance training. This is often overlooked, but directly addresses one of the most dangerous outcomes in elderly health: falls. Simple balance exercises, practiced consistently, reduce fall risk significantly. They do not require a gym. They require 10 minutes and a willingness to stand on one foot near a wall. These are the metrics. These are the targets. Not a number on a scale, not a BMI category that was never designed to assess an individual elderly person's survival prospects. Here is where this story lands, and it is worth feeling the full weight of it. The man at the beginning of this video, the 71-year-old who reached his ideal BMI and died 14 months later, was not failed by a careless doctor. He was failed, in a sense, by a framework built for a different population, applied without sufficient nuance to one of the most biologically complex phases of human life. His doctor was doing what good doctors do, following the evidence as it was understood, applying the guidelines she was trained to trust. The tragedy is not that she was negligent. The tragedy is that the guidelines themselves were incomplete, and the gap between what the research was beginning to show and what was happening in examination rooms across the country had not yet been closed. That gap is still not fully closed, but it is narrowing. Geriatric medicine is asking harder questions. Researchers are pushing back against the reflexive application of middle-age weight targets to elderly bodies. And slowly, too slowly perhaps, but genuinely, the conversation is changing. What you can do right now is be ahead of that conversation. If you are over 65, or if someone you love is, bring these questions into the next medical appointment. Ask not just about weight, ask about muscle. Ask about strength. Ask about fall risk. Ask whether weight loss is specifically indicated for your situation, or whether it is a default recommendation that may not account for the unique biology of your age. The most powerful thing a patient can do is ask better questions. And the most powerful thing medicine can do is take those questions seriously. There is something quietly remarkable about a body that has survived 70 years or 80 or more. It has adapted. It has compensated. It has developed strategies that science is still working to fully understand. When an aging body holds on to weight, when it resists the caloric restriction that every diet program demands, that resistance may not be failure. It may be intelligence, an evolutionary memory of lean winters and scarce fuel encoded across millions of years of survival, whispering to the body, hold on, you are going to need this. The slightly overweight 70-year-old who has felt vaguely guilty for years about a number on a scale, who apologizes to her doctor for not succeeding at something her body may be actively and wisely resisting. She may not be failing at health. She may be practicing a form of it that medicine is only just beginning to understand. That does not mean ignoring your physician. It means working with them more deeply, more specifically, more intelligently than a scale number allows. Because the goal was never a number. The goal was a life, long, strong, functional, present. And the map to that life looks nothing like the one most of us were given. If this video made you think differently about aging, about the bodies of people you love, share it with someone who needs to hear it. Drop a comment below telling me whether your own doctor has ever talked to you about muscle mass versus weight. I want to know what the conversation looks like in the real world. And if you are not yet subscribed to Dr. Victoria Reed, this is the moment. There is more to uncover. We are just getting started.